everyone, this is Danelle. I'm a practical nurse, and in my previous video I talked about the importance of delegation a little bit, how that's a major topic to know for your NCLEX exam and for your life, for your nursing practice. So scope of practice is super important because you want to remain within the confines of your scope of practice, or it is very illegal and you will get in trouble. So RNs can delegate to LPNs. LPNs can delegate in most states to unlicensed assistive personnel like CNAs. PNs cannot delegate to RNs, and assistive personnel cannot delegate to PNs or RNs. So the hierarchy is RN, PN, AUP. So you're going to think of your rights of delegation: right task, right circumstance, right person, direction, communication, supervision, and evaluation. So when you are delegating to an assistive personnel, and this comes up a lot in practice tests and on the NCLEX exam, delegating to UAPs, you're going to want to be very specific. It's all about specificity. So an example is delegate a UAP to assist Mr. Martin, so exactly what patient, in room 312, that's exactly where, with a shower and a bath, exactly what you're doing, before 9:00 a.m., exactly when. So that's a good example of a very specific direction, and you'll have like 4 choices, and some of them will seem kind of specific, but maybe, they're not that specific. It'll be like, help the patient with dementia, ambulate at 2200 or something. You want more specificity than that. If a choice is given with more specificity, it's always about the best choice. It's not always going to be perfect. So think predictable / minimal risk when you are delegating to an assistive personnel. You want those patients to be stable. You do not want to delegate tasks to assistive personnel if the patient is not stable. An unstable patient is someone who's like 1 day post-op, someone who is having an acute issue that needs to be tended to. Their vital signs are all over the place. That is an unstable patient. You do not want to delegate. Okay, so let's start with assistive personnel. They can help with ADLs, activities of daily living, bathing, grooming, dressing, toileting, ambulating, feeding, but without swallow precaution. So again, thinking about stable versus unstable, you can put someone who has an absent gag reflex or swallowing issues in the unstable category. Mouth care, they can do mouth care. Skin care, they can use barrier creams, but they cannot put medicated creams on patients. So that is something to be acutely aware of. They can put creams, lotions, but not medicated. And they can take care of general hygiene. So they can also position, bed make, do routine tasks. Here's another kind of odd one: specimen collection. They can collect sputum and urine. They cannot do cultures. They can just collect sputum and urine. Remember that. They can do INOs for lots of cases. Some they cannot. They can document. Okay, so here's some kind of outlier situations. They can assist with incentive spirometry post-op. So this is a client who maybe does not fall into the stable category necessarily, but incentive spirometry is non-invasive, and as long as the client is not having some sort of breathing problem or anything like that, you can delegate to a UAP to do this. I have never seen this question or this answer show up, the incentive spirometer thing, but about this topic, but just know that that's a thing. They can empty post-op fully, so they can jot down the output for Foley's post-op. That's kind of an odd thing too. And again, as long as there's no complications or the patient is unstable. Again, they can do a barrier cream, they can do a cream but unmedicated, can assist with meals if the patient is stable, cannot care for clients with chest tubes. This is another kind of weird thing, right? So it's on a case-by-case basis kind of with these sorts of things. They can do the post-op Foley output. They cannot care for clients with chest tubes at all. So, you know, you'd think they could maybe jot down the output for a chest tube. They can't do that. They also cannot do INOs for ostomies. So when you're thinking through, when you have choices presented and you're like, oh God, like some of these things seem kind of invasive, I just don't really know, think about if a nurse would want to assess or evaluate the situation. If someone has just, you know, gotten the surgery to get a colonostomy, the nurse will want to see what color the ostomy is, if there's drainage, you know, what's going on. So normally this is not delegated to the UAP. Okay, UAPs can check vitals if the patient, again, is stable. If the vitals are changing and, you know, they're going through some serious acute episode, you do not want to delegate to a UAP. Also, if a UAP takes a vital sign or takes the vitals from someone and then maybe the vitals are taken again half an hour later, and they're totally different, you have to retake the vitals. Or if baseline vitals are a certain way and UAP takes them and they're like way elevated or way lower than normal, you want to retake that too. Okay, as a nurse, you want to retake it. What else? This is another kind of odd thing. UAPs can put condom catheters on patients. So when I first saw this question in some practice tests, I was like, what the heck is a condom catheter? I had no idea. But I just thought, you know, what's a condom? What's a catheter? Maybe it's non-invasive, and that ended up being the answer. So they can do that. They can put condom catheters on patients. They cannot put other sorts of catheters in patients. Okay, that is all that I can think of for now. That's a lot of information from a lot of different sources, and I hope that gives you a clearer picture of what can be delegated to UAPs. Moving on to LPNs. PNs, RNs can delegate to PNs, right? What can be delegated to PNs are monitoring findings, reinforcing client teaching from a standard plan of care. So LPNs cannot do initial teaching, but they can reinforce teaching after the RN has done the initial teaching. They can perform tracheostomy care, they can suction, they can check NG tube patency, administer enteral feedings, insert urinary catheters, administer medication. In some states, LPNs cannot do IV meds. So yeah. Beyond that, LPNs can contribute to the care of stable clients, not those with complicated conditions. They can also participate in health promotion, counseling for clients. So this kind of threw me off. They cannot do the teaching, the initial teaching. They can reinforce teaching, but they can do initial teaching, if you will, on things like diet, things that aren't about their plan of care beyond basic things like diet. So I did get a question about this on some practice exam, and I was like, what even is going on that they can teach about diet? Because I've just been taught, you know, LPNs can't do the initial teaching, but they can sometimes. They can also evaluate a client's response to a nursing intervention. They can assist in developing unit policies and procedures affecting client care. So LPNs are, of course, part of the health team, and they can actually help develop policies. So again, LPNs, they can do invasive things. They can do trach care, they can do wound care, they can do ostomy care. If the ostomy is new, maybe the RN wants to assess, and this brings me into the RN's role. So we've covered a lot here, and now it's just about seeing what the RN can do that's not anything the LPN or UAPs can do. So RNs can do anything the UAPs do and anything the LPNs can do, plus these few things. Think of the mnemonic TAPE, T-A-P-E. T, teaching, A, assessment, P, planning, E, evaluation. The initial teaching, RNs do. The assessment, say we have a new patient coming into the hospital or the clinic, they do the initial assessment of that patient, planning and evaluation. RNs can administer blood products. LPNs cannot do that. When RNs administer blood products, they have to stay with their client for the initial 15 minutes of the infusion, because there are things called infusion reactions, so you have to make sure nothing's going on. They can also administer IV medications, which I said previously in some states LPNs cannot do that, but RNs can always do that. All right, that is all. I want to keep this video shorter than the last, and I hope this was informative. If you have any questions, if you need more clarification, just write a comment below, and please like and subscribe. Thank you so much for watching.